SwayamPrabha. Digital India. Educated India.
Hello, I am Dr. Medora Dias from Goa Medical College. The topic we are going to discuss today is the abdominal aorta and the inferior vena cava. Some of the clinical relevant aspects of the abdominal aorta and inferior vena cava that we will be studying today are palpation of the abdominal aorta, the inferior vena caval filter, inferior vena caval tumor extension and aortic aneurysm, among other clinical entities. Let's talk about the introduction to this abdominal aorta. This is the main blood vessel which is supplying blood to the abdomen and the inferior extremities. Its length is about 13 centimeters. It begins at the level of T12. You can see here. At the level of the T12 vertebra, it enters the abdomen by piercing the diaphragm at an aortic hiatus, and it proceeds downwards till the level of the fourth lumbar vertebra. It ends at L4 by dividing into the right and left common iliac arteries. If you talk about the surface anatomy or surface marking of the abdominal aorta, it starts from a point 2.5 centimeters below the xiphoid process tip and extends downwards to a point 1.5 centimeter below and a little to the left of the umbilicus, near the midpoint of a line connecting the summits of the iliac crests, which is also called the intercristal plane. As the aorta descends in the abdominal cavity, the diameters tend to decrease. It starts at a diameter of around 25 millimeters at the 11th rib and goes to a size of 19 millimeters at its bifurcation into the two common iliac arteries. Let's talk about the relations of the abdominal aorta. Why are the relations important? We need to study what lies anterior, posterior and on either side of the abdominal aorta, because we need to know, in case of the event of a surgery, what are all the structures that could be injured that lie around or surrounding the abdominal aorta. Let's start with the anterior relations. If you look at this figure here, this is the abdominal aorta, and you can see from superior to inferior there is the celiac plexus around the celiac trunk. Then you look at the body of the pancreas which crosses it along with the splenic vein. Below will be the inferior left renal vein. You can see the horizontal part of duodenum next, and then will be the parietal peritoneum with the infracolic compartment and coils of the small intestine. Let's look at the posterior relations. Now, the abdominal aorta lies related to the lumbar vertebrae, slightly to the left of the midline. It is also related to the left lumbar veins posteriorly. To its right, you can see here, lie the inferior vena cava along with the azygous vein, cisterna chyli, diaphragm and the celiac ganglion. To its left will lie the left crus of diaphragm, left celiac ganglion as well as the inferior mesenteric artery. Now let's discuss the branching pattern of this abdominal aorta. The abdominal aorta has several branches. In order to simplify and understand the branching pattern, let's talk about vascular planes. If you look in this diagram, this is the abdominal aorta and this is a transverse section. So that's anterior, this is posterior and that's on either side. The midline anteriorly has 3 unpaired branches which are also visceral branches, that's labeled as number 1. There are lateral paired branches which are also visceral, for example the renal arteries, which go to the lateral paired organs. The third plane of branching is a posterolateral branching which goes to the diaphragm or the body wall. There are another 2 sets of branches, the terminal branches, that is the 2 common iliac arteries, and the median sacral artery which lie in another plane inferiorly. Let's look at a tabular description of all the various branches of the abdominal aorta. We start with the anterior midline, unpaired visceral branches to the digestive tract. Which are these? The celiac, superior mesenteric and inferior mesenteric arteries. Next come the lateral paired branches which are also visceral to the urogenital and endocrine organs, that's suprarenal, the renal, the gonadal which is testicular and or ovarian. Next is the posterolateral branches which are paired and they are segmental, supplying the diaphragm and the body wall. There are the lumbar arteries, the inferior phrenic and subcostal arteries. Let's summarize what we have just learnt. We are talking about our subject today, which is the abdominal aorta. This abdominal aorta is a continuation of the thoracic aorta, which enters the abdominal cavity at the level of T12 through the aortic hiatus of the diaphragm. It then lies on the lumbar vertebrae and ends at L4 by dividing into 2 common iliac arteries and the median sacral artery. It is related to many important structures which include the celiac ganglion, the pancreas, the left renal vein, amongst other structures. It also has an importance of a narrowing of this vessel from 25 millimeters above to about 19 millimeters at its bifurcation. We also studied the branches of the abdominal aorta, the anterior unpaired visceral branches, the celiac artery, superior mesenteric and inferior mesenteric, then the lateral paired visceral branches like the suprarenal, the renal and the gonadal, and the posterolateral paired body wall branches which includes the lumbar arteries, inferior phrenic and the subcostal arteries. Not to forget, it also gives the 2 terminal branches, the 2 common iliac arteries as well as the median sacral artery. Let's go into a further detail about each of the branches of this abdominal aorta. Let's start with the unpaired visceral branches. There are 3 in number. If you look in this diagram, you can see here the celiac trunk, the superior mesenteric below that and the inferior mesenteric lowest. The celiac trunk is the artery to the foregut, the superior mesenteric is the artery to the midgut, and the inferior mesenteric is the artery to the hindgut. I am sure you all must be knowing about foregut, midgut and hindgut. These are the 3 components of the gastrointestinal tract which you will study when you learn embryology. Let's look at the first of these branches we have mentioned, the celiac trunk. The celiac trunk is a very short vessel which immediately divides into its various branches. These are the left gastric artery, the splenic artery and the common hepatic artery. This celiac trunk is related to various structures like the diaphragm, the liver, the stomach, the pancreas and spleen as well as the celiac ganglion and plexus of nerves. Coming to the first branch of the celiac trunk, which is the left gastric artery. The left gastric artery you can see here. This is the left gastric artery which supplies esophageal branches It runs to the left and then runs down the lesser curvature of the stomach to anastomose with the termination of the right gastric artery. It is important to note here that some of the esophageal branches of this left gastric artery anastomose with the thoracic branches of the esophagus coming from the thoracic aorta. Next is the splenic artery. This is a very long and tortuous artery which runs right up from the celiac trunk and the stomach bed posterior to the stomach, and it goes right up to the hilum of spleen. Along its way, it gives numerous branches like pancreatic branches. It also gives off short gastric arteries to the fundus of stomach, gives off the left gastroepiploic artery which runs along the greater curvature of stomach, and then terminates by dividing into splenic branches. Now these splenic branches are important because the spleen is a very vascular organ, and any injury to the spleen could result in a lot of blood loss or hemorrhage. We have to always remember that the spleen has two vascular segments, and each of these segments can be removed by a procedure called a segmentectomy of the spleen. So, knowing the arterial supply of the spleen becomes important. The common hepatic artery, this is the next branch of the celiac trunk. It runs to the right and gives off the gastroduodenal artery, the right gastric artery and the proper hepatic arteries. The right gastric artery runs along the lesser curvature of stomach and anastomoses with a branch of the left gastric artery. The gastroduodenal artery passes posterior to the junction of the pylorus and the first part of duodenum and gives off the right gastroepiploic artery and the superior pancreaticoduodenal artery. The right gastroepiploic artery supplies the greater curvature of stomach and anastomoses with branches of the left gastroepiploic artery. The superior pancreaticoduodenal artery supplies the superior part of duodenum up to the duodenal papilla as well as portions of the pancreas. There is another artery called the supraduodenal artery of Wilkie, which when present is lying anterior to the duodenum and separates the pylorus from the first part of duodenum. The hepatic artery, which gives off the proper hepatic artery, then bifurcates into the right and left hepatic arteries. The right hepatic artery also gives off the cystic artery, which supplies the gallbladder. We have described the three branches of the celiac trunk, but remember, there are a lot of variations in the arterial branching pattern here. Sometimes the celiac trunk itself is absent and the branches directly arise from the abdominal aorta. There could be anastomotic communications between branches of the celiac trunk and other vessels as well. Sometimes the left gastric artery gives off the left hepatic artery, or common hepatic artery may arise directly from the superior mesenteric instead of the celiac trunk. So, we have studied the celiac trunk and its numerous branches. Let us move on to the next midline branch, which is the superior mesenteric artery. This is the artery of the midgut. The midgut is the portion that extends between the duodenal papilla and the transverse colon. This artery arises a centimeter below the celiac trunk and runs downwards, forwards and towards the right. It runs, if you look in this figure, right down to the ileocecal junction and gives various branches. The relations of the superior mesenteric artery. The superior mesenteric artery in a lateral view is divided into an initial part and the next part. This artery buds off from the abdominal aorta anteriorly and lies over the posterior abdominal wall deep to the pancreas and splenic vein and superficial to the left renal vein. This left renal vein lies between the superior mesenteric artery and the aorta, and this is called as the abdominal nutcracker, wherein the left renal vein gets compressed between the superior mesenteric artery anteriorly and the aorta posteriorly. The second segment or the next part of the superior mesenteric artery passes anterior to the pancreatic uncinate process and horizontal part of duodenum, enters the root of the mesentery to supply the small intestine. It also crosses the inferior vena cava, the right ureter and the right psoas, major muscle. It is accompanied by the superior mesenteric vein on its right side, which drains into the portal vein. What are the branches of the superior mesenteric artery? As I said, it is the artery of the embryonic midgut. It is going to have branches supplying the duodenum, the jejunum and the ileum. So, it gives off the inferior pancreatico-duodenal artery. It gives off, you can see here, numerous ileal and jejunal branches from its left side. Then it proceeds to go down to the ileocecal region and terminate by anastomosing with a branch called the ileocolic artery. Another branch from the right side is the right colic artery, and then there is the middle colic artery. The right colic artery supplies portions of the ascending colon, also portions of the appendix. The middle colic artery supplies portions of the transverse colon and anastomoses with branches of the inferior mesenteric artery. There is a large anastomosis by two vessels called the arc of Riolan and the marginal artery of Drummond, which anastomose the blood supply between the superior mesenteric artery and the inferior mesenteric artery. Let us now look at the inferior mesenteric artery branches. The inferior mesenteric artery is the artery of the hindgut, and it supplies blood to portions of the gut extending from the transverse colon right down to the superior half of rectum. The branches of the inferior mesenteric artery are the left colic artery, 3 sigmoidal branches and the superior rectal artery. The left colic artery runs towards the left side, supplies the descending colon, parts of transverse colon and anastomoses with the middle colic branch of the superior mesenteric artery. That is the anastomosis we were talking about, the arc of Riolan and the marginal artery of Drummond. The superior rectal artery supplies blood to the rectum and anastomoses with 2 other branches, which are the middle rectal artery from the internal iliac and the inferior rectal artery from the pudendal. So, the superior rectal artery is an important communication and more important in cases of sigmoid surgery when you need an anastomosis or another vessel to supply portions of the sigmoid colon in case the sigmoid vessels are compromised. The superior rectal artery is a special mention. It is a direct continuation of the inferior mesenteric artery and supplies the upper half of rectum and anal canal. It crosses the left common iliac vessels and descends into the pelvis between layers of the sigmoid mesocolon up to the level of S3. It supplies the superior portions of rectum and anal canal and anastomoses with other branches like the middle rectal artery and the inferior rectal arteries. Collateral arterial branches. There are a lot of variant patterns of branching in blood supply to the gastrointestinal tract, and collateral circulation is very important because if there is any surgery of the viscera, there can be anastomotic supply from other vessels if any vessels are compromised during the surgical procedure. There can be communications between branches of the celiac axis itself or between celiac axis and superior mesenteric, between superior and inferior mesenteric or between inferior mesenteric and the middle rectal branch of internal iliac artery. So, these collateral branches and their anastomosis have a significant importance in cases of gastrointestinal tract surgery. These are some of the collateral arterial branches we were talking about. The first one is the arc of Buller. This is between the celiac artery or the celiac trunk and the superior mesenteric. In this figure, you can see the arc of Riolan, which is between superior and inferior mesenteric. The marginal artery of Drummond also is an anastomotic vessel which is given blood supply by both inferior mesenteric as well as the superior mesenteric. Let us summarize what we have just been talking about. We have described in detail the three anterior midline branches of the abdominal aorta, which are called the visceral branches, and they supply parts of the gastrointestinal tract. The artery of the foregut, being the celiac trunk, gives off branches like the left gastric artery, the common hepatic artery and the splenic artery. These arteries in turn give off various branches and supply the parts of the gastrointestinal tract between the stomach, the esophagus and the papilla of duodenum. Then there is the superior mesenteric artery which supplies the midgut, which is from the duodenal papilla till portions of the transverse colon. These branches include ileal branches, pancreatico-duodenal branches, branches to the right colon, cecum and appendix, as well as branches to the transverse colon. Then we spoke about the inferior mesenteric artery, which is the artery of the hindgut. This gives branches to the rest of the tract right up to the upper half of the rectum and anal canal. And one of the important branches of this vessel is the superior rectal artery and its anastomosis with sigmoid branches and the remaining rectal arteries from internal iliac and from pudendal systems. We also talked about collateral blood supply to the gut and special anastomotic vessels like the arc of Buller, the marginal artery of Drummond and the arc of Riolan. So, we have studied the anterior midline unpaired visceral branches of the abdominal aorta. Let us now proceed to the paired visceral branches. These are the middle suprarenal arteries, which you can see here, the renal arteries and the paired gonadal arteries, either testicular or ovarian. The middle suprarenal arteries, these supply blood to the suprarenal glands. You can see them here, the middle suprarenal arteries, and they anastomose with the other two branches of the suprarenal glands, the superior suprarenal and the inferior suprarenal arteries. The superior suprarenal artery is a branch of the inferior phrenic, whereas the inferior suprarenal artery is a branch of the renal artery. The renal arteries arise laterally at right angles at the level of L1 or L2, the left renal artery being at a slightly higher level than the right renal artery. The right renal artery is longer, it passes posterior to the inferior vena cava, whereas the left renal artery is shorter and passes posterior to the left renal vein. The blood supply to the kidney is important because at any given point of time, the kidney has 25% of the cardiac output. So, blood loss in kidney damage could be fatal, and that is why the kidneys are important in their blood supply, and that is why we study the renal arteries. There can be accessory renal arteries which can enter the inferior pole of the kidneys. The kidneys have vascular segments, each kidney having 5 vascular segments. The gonadal arteries could be the testicular artery or the ovarian artery. The testicular artery, which is present in males, arises from the abdominal aorta obliquely. It passes downwards retroperitoneally on the psoas major muscle, crosses the iliac fossa, traverses the inguinal canal and enters the scrotum to supply the testis. It also supplies the abdominal part of the ureter and the epididymis. It anastomoses with branches of the cremasteric artery and artery of the dectus deferens. The ovarian artery is present in females. It arises in the same way as the testicular artery. It descends retroperitoneally but remains in the pelvis and enters the suspensory ligament of the ovary. It also supplies the abdominal and pelvic ureter, the ovaries, the ampullary end of the uterine tubes and the round ligament of uterus. It anastomoses with the uterine artery via the tubal branches. Now we will talk about the dorsal branches. These are the inferior phrenic arteries, which you can see here, paired inferior phrenic arteries, and below that there are the lumbar arteries. There are 4 pairs of lumbar arteries and the single median sacral artery. The inferior phrenic artery, as the name implies, supplies the diaphragm. It also supplies the superior suprarenal artery to the suprarenal glands, and it also supplies body wall branches. The 4 pairs of lumbar arteries supply the posterior body wall, and the single median sacral artery, which arises inferiorly, is the actual continuation of the abdominal aorta and descends down over the sacrum and coccyx. If you look at the lumbar arteries, this is what you see. So, that is the abdominal aorta giving off the lumbar arteries. The lumbar arteries branch off into a dorsal branch supplying the dorsal muscles of the back like erectus spinae. It also gives off a branch to the spinal cord, which are the radicular arteries, and a lateral branch to the abdominal wall. This figure shows you the abdominal aorta terminating at the level of L4, L5 into the 2 common iliac arteries. The 2 common iliac arteries are continuations which further branch out into an internal iliac and external iliac. If you look at the terminal branches and their surface anatomy, the common and external iliac arteries, you draw a line, slight lateral convexity from a point opposite the bifurcation of the abdominal aorta to the midinguinal point. The upper 1/3 of the line represents the common iliac artery and the lower 2/3 of the line represents the external iliac artery. Let us summarize what we have just spoken about. The inferior phrenic artery is a branch of the abdominal aorta which supplies the diaphragm as well as it gives the superior suprarenal arteries to the suprarenal gland. The middle suprarenal artery is a branch that supplies the suprarenal gland. Renal arteries are large vessels which supply the kidney as well as they give the inferior suprarenal artery. There can be gonadal vessels, the testicular arteries or the ovarian arteries. Testicular arteries supply abdominal ureter, the testis and epididymis. The ovarian arteries supply the abdominal and pelvic ureter, ovary, uterine tube and round ligament of uterus. There are subcostal arteries and 4 pairs of lumbar arteries which supply the musculature of the back, vertebral column as well as the nerve roots. The terminations of the abdominal aorta are the right and left common iliac arteries which divide into internal and external iliac arteries. Last is the median sacral artery which is a direct continuation of the abdominal aorta, and this gives off the 5th pair of lumbar arteries. Let us start with the inferior vena cava. Now we have completed with the abdominal aorta, which is the first part of our topic today. Let us proceed with studying the various aspects of the inferior vena cava. The inferior vena cava is the largest vein which drains blood from the inferior extremities as well as from the abdominal regions and opens into the right atrium of heart. It is the largest vein in the body and it is formed at the level of the meeting point of the two common iliac veins and then ascends up, pierces the diaphragm at the level of T8 and enters the right atrium of heart from below. Let's look at the surface anatomy of the inferior vena cava. This can be drawn from a point on the intertubercular plane 2 to 3 centimeters to the right of the midline upwards till the sternal end of the right sixth costal cartilage. Note from this figure that the inferior vena cava extends to the right of the abdominal aorta and it ends at a higher level. What is the course of the inferior vena cava? As we just said, it ascends upwards, it lies slightly to the right of the midline and it passes behind the right lobe of liver, grooving the bare area, and it is anchored by a thin strong ligament to the diaphragmatic hiatus to the caudal lobe of liver, and it has a small intrapericardial course in the thorax and opens into the right atrium. Except for the gonadal vessels, all the tributaries of the inferior vena cava do not have valves. The relations of the inferior vena cava: posteriorly, it rests on the right crus of diaphragm with right suprarenal gland. Lower down, it lies on the right psoas major. It also lies on arteries from the aorta like the renal artery, inferior phrenic, right suprarenal and the right third and fourth lumbar arteries. What are the relations of the inferior vena cava? The posterior relations are the right crus of diaphragm with right suprarenal gland, as can be seen here in this figure, the right psoas major, the right inferior phrenic artery, right suprarenal artery and the right fourth lumbar arteries. Anterior relations of the inferior vena cava are the liver with the epiploic foramen, duodenum, the bile duct, the horizontal part of duodenum, gonadal vessels, the mesentery root. Coming to tributaries, what are all the veins that drain into the inferior vena cava? There are two anterior tributaries which are the hepatic veins. There are lateral visceral tributaries like the right suprarenal, the right renal vein, the left renal vein, the right testicular or right ovarian vein. There are 5 lateral abdominal wall tributaries being the inferior phrenic veins and the 4 lumbar veins, and 3 tributaries which form the inferior vena cava, the 2 common iliac veins and the median sacral vein. So, these are all the tributaries which drain into the inferior vena cava. The lumbar veins. Drainage of the lumbar veins is as follows. The 5th lumbar vein drains into the iliolumbar and the common iliac veins. The 3rd and 4th drain into the inferior vena cava. The 1st and 2nd drain into the azygous and hemiazygous systems of the thorax. In case the inferior vena cava is blocked, the ascending lumbar veins become important collateral channels between the lower and the upper parts of the body. Let's summarize what we have studied about the inferior vena cava. The inferior vena cava is the largest vein in the body. It begins by the joining of the right and left common iliac veins at the level of L5 and then ascends up a little to the right of the midline to pierce the diaphragm at the level of T8 and open into the right atrium of heart. It is valveless and it is related to various structures like the liver, the duodenum, portal vein and bile duct, the mesentery root. It has tributaries like the hepatic veins, the right and left renal veins, the right suprarenal vein, the right lumbar veins and the median sacral vein. If the inferior vena cava is blocked, ascending lumbar veins become important collateral channels between the lower and upper halves of the body. Now that we have covered our topics, let's proceed to the clinical anatomy relevant to the abdominal aorta and the inferior vena cava. First of all, let's see how do you palpate the abdominal aorta. Why is this important? For one, it's palpating a vessel. Secondly, you could cause pressure on the same region where you can palpate this artery. Suppose there is hemorrhage from the inferior extremities and you would like to control this hemorrhage to save the life of a patient as a first aid measure. How do you palpate the abdominal aorta? In children and lean adults, this aorta can be palpated by compressing it against the body of the fourth lumbar vertebra. So, you apply firm pressure over the umbilicus as shown in this figure, and this can be used to control hemorrhage from lower extremity wounds and from pelvic wounds and save the life of a patient. Now, a tumor of the pancreas which lies over the abdominal aorta may transmit its pulsations to the anterior abdominal wall and mistake these pulsations for the presentation of an aortic aneurysm. So, this has to be kept in mind if pulsations of the abdominal aorta can be visible on the anterior abdominal wall. Why is the abdominal aorta important? Because it is related to a lot of surgical entities. It is related to the thoracic duct, azygous vein, it passes through the aortic hiatus, it can undergo a syndrome called the median arcuate ligament syndrome, where there is compression of this abdominal aorta or the celiac trunk by the opening in the diaphragm. There is a syndrome called Dunbar's syndrome which is associated with this. There can be an aortic aneurysm which could rupture, causing a fatal hemorrhage, and the patient's life is at risk. This is an example of an aortic aneurysm. You see this large dilatation here. There are different types of aneurysms. One is a dissecting type, or there can be a true aneurysm type. Here you see there is an abnormal bulging of the lumen of the abdominal aorta, and this could rupture at any moment. Since the abdominal aorta is going to be a vessel having a large amount of blood at any given point of time, definitely this kind of hemorrhage will be fatal. If an abdominal aortic aneurysm is found, it can be treated surgically, or you could use an aortic stent graft. So, in patients where surgery cannot be performed or they are unfit for surgery or any other reason, an aortic stent graft can be inserted and sutured to prevent the aneurysm from rupture. Other clinical entities of the abdominal aorta are coarctation. This is relatively rare in the abdominal aorta. It is more common in the thoracic aorta, but it could occur in the abdominal aorta. Coarctation of an aorta is nothing but an abnormal narrowing of the artery, causing an impediment of the blood flow in it. Another clinical entity is an embolic blockage in the abdominal aorta. If there is a thrombus which dislodges and gets into the abdominal aorta, it could travel right down to the bifurcation of the abdominal aorta into the two common iliac arteries, since that is the narrowest part of the abdominal aorta. What would be the result? The lower limbs blood supply is going to be compromised, leading to severe ischemia of either or both the lower limbs. Pelvic surgeries involve ligation of vessels, sometimes permanently. For example, sometimes you need to ligate the internal iliac artery. In these cases, how is blood supply maintained to what the internal iliac supplies? By anastomosis of vessels like the inferior mesenteric artery, superior rectal, the middle rectal, inferior gluteal, deep artery of thigh, the lumbar arteries, iliolumbar arteries with branches of the abdominal aorta and the internal iliac artery, this kind of collateral circulation is maintained and internal iliac artery can be ligated with no damage done. Inferior vena cava compression or obstruction and the collateral channels. The inferior vena cava can be compressed because it is a vein and it has a thinner wall. It can be compressed by retroperitoneal malignant tumors, the gravid uterus or a giant fibroid. This produces unilateral or bilateral extremities, varicosities and swellings. The most common vessels in a collateral circulation here are the ascending lumbar veins, the vertebral plexus, azygous and hemiazygous veins, and veins of the anterior body wall like the inferior epigastric, superior epigastric, circumflex iliac, lateral thoracic, thoracoepigastric and internal thoracic vessels. Renal tumors or renal cancers could spread into the inferior vena cava. They could spread locally, they could spread further higher up, they can even enter the right atrium and infiltrate the heart. This is an inferior vena caval filter which is introduced around the inferior vena cava in order to stop a thrombus from dislodging from thrombosis of deep veins of the lower extremities and getting into the atria and causing a pulmonary embolism. So, this is a procedure done to prevent death due to pulmonary embolism. Let us now summarize all that we have learned today. We are talking about the abdominal aorta and the inferior vena cava. The abdominal aorta is the largest artery in the body. It enters the abdominal cavity by piercing the diaphragm at the level of T12 and it runs right down to L4 to divide into the two terminal common iliac arteries, right and left, as well as the median sacral artery. The various branches of this abdominal aorta include anterior midline, unpaired visceral branches to the gastrointestinal tract like the celiac trunk, superior mesenteric artery and inferior mesenteric artery, each supplying portions of the foregut, midgut and hindgut respectively. We also studied the paired lateral visceral branches like the renal arteries, the middle suprarenal arteries and the gonadal arteries, testicular or ovarian. We also took a look at the paired lateral body wall branches like the lumbar arteries, the inferior phrenic artery. The terminal branches, that is the two common iliac arteries, further divide into internal and external iliacs which give their own respective branches. We have studied about the inferior vena cava. How is it formed? By joining of the two common iliac veins, and this ascends right up through the diaphragm at the level of T8 and opens into the inferior aspect of the right atrium. The inferior vena cava is very important. It is the largest vein of the body. It is entirely valveless except the gonadal veins and it receives various tributaries like the renal veins, right suprarenal, the lumbar veins mostly on the right side, inferior phrenic, and it has communications with the azygous system and the hemiazygous system of veins, providing collateral pathways in case the inferior vena cava is compromised. With this, I would like to conclude my topic. Thank you.